Welcome to the ICSI module with EmbryoDirector.com. My name is Dr. Tony Anderson, and I'm happy you're here because your success is my success. The objectives of this portion of the module is to know where we came from, and the history of micromanipulation, some of the pros and cons of using ICSI. Then we'll get into the details of some of the technical application of the ICSI procedure. Louise Brown was born on July 25, 1978, and until the late 80s, the male factor diagnosis required the use of donor sperm for insemination. Subzonal sperm insertion was the process of inserting the sperm into the paravitelline space just under the zona pellucida. This primarily resulted in no fertilization and polyspermy. And during the same time, experiments were being done with cutting a hole or a slit in the zona with a sharp needle and allowing sperm to penetrate the zona through this hole. Unfortunately, this resulted in the same outcome as Susie with low or no fertilization and polyspermy. The landmark study by Van Sturtevant and others in 1992 described intracytoplasmic sperm injection. At this time, it revolutionized the world of assisted reproductive technologies, and today ICSI is more widely used than the original intent of the 40 to 50% of the patients that historically had to use donor sperm. What are some of the advantages and disadvantages of utilizing ICSI in the ART lab? Historically, conventional insemination resulted in low or no fertilization rates, approximately 10% of the time. Additionally, without the natural block to polyspermy, there is a higher incidence of abnormal fertilization in some cases. Although conventional insemination is a more natural selection of sperm, it is thought that the oocytes that don't fertilize and those that fertilize with polyspermy would not have resulted in a good quality embryo. Some recent studies have shown that in knockout mice that oocytes may have a system for selecting the sperm that is optimal for the best genetic outcome. But these are just speculations, and the studies are still ongoing. ICSI, on the other hand, it was originally designed for the 50% of the population that is male factor, 50% of the diagnosis that is male factor. Rarely results in no fertilization or low fertilization. While maximizing the fertilization of the mature oocytes, there is also the human bias of the selection of the sperm, and it can overcome some of the more difficult male factor problems when there's azoospermic or very low sperm counts. There are some common and variability of some of the equipment that one could use for ICSI. All systems typically have Hoffman modulation with the 10, 20, and 40x objectives. And that is about the only commonality between laboratory micromanipulation setups. A number of manipulators are available, but the most common are the Narshigi, research instruments, and the Eppendorf. In the beginning, there were only oil injectors, and today a wide range of injectors, ranging from the mushrooms to the IM11 air injectors, and also the Eppendorf oil injectors. The microtool quality is critical and can make or break the success of the ICSI procedure. Too large of an ICSI needle may cause higher degeneration rates, and there is more forgiveness for the size of the holding pipette that you would use. It's just the idea is to pick one that you like and stick with it. Hyaluronidase, and some vendors call it cumulase, has an activity level of 80 international units. I have personally diluted it out in 1:1, make it 40 international units with little problems. Hyaluronidase is an enzymatic removal of the cumulus that must be done prior to ICSI. Ironically, it is also one of the last chemicals we use that is animal derived from the bovine testes. Technically, the cumulus has performed its job producing the follicular phase hormones during the stimulation. Our job now is to mechanically manipulate the insemination process, and it starts with the removal of the cumulus. We start with making sure the hyaluronidase is brought to the correct temperature of 36 to 38 degrees Celsius. It takes a minimum of 1 hour for the tube of hyaluronidase to warm up to get to temperature, and usually should happen early in the morning when starting up the laboratory. Place the oocytes in the drop of the hyaluronidase and immediately use a 275 or 300 micron tip to remove the big cumulus, and then move those oocytes immediately to a bicarbonate culture drop. This is the first part and is also the most critical part time-wise. And I say to do the number of oocytes you can that you can get out within at least 1 minute. Once out of the hyaluronidase, now you have a little extra time for the removal of the cumulus closer to the zona, using either the 170 or the 140 micron tips. Just important to note that an oocyte on average is around 150 microns, and the 300 micron is the safest tip to use to remove the big portion of the cumulus. When you get down to 140, you have to be careful, and I typically only use the 140 during the hyaluronidase process and the 170 for the freezing process when freezing embryos and oocytes. The 300 micron tip is what we use for all my moving because it's larger than the 150 micron tip and it's safe without damaging the oocyte. PVP, polyvinyl pyrrolidone. I have every student say this and tell me what it sounds like in my one-on-one training. One says poly, mini, and vinyl plastic. It becomes apparent that this is not a naturally occurring compound found in the reproductive system. That being said, a good Google search indicates that PVP is water soluble and is also used as an emulsifier in pill manufacturing. It's found in glue sticks and other glues, so my conclusion is that if the FDA says we can eat it, it must be okay to inject a few nanoliters into the oocyte. It's the most commonly prepped with a 7 to 10% volume-to-volume solution. I just have to say that I'd like to tip my hat to the people that went to go do ICSI and said, hey, let's try this and use PVP to slow down the sperm and inject it into the oocyte and hope it doesn't affect the oocyte. At any rate, we've been using PVP since the beginning of ICSI in 1992, and during my master's program, I was given the task of trying to determine other alternatives to PVP and did ICSI for about a year without PVP. It didn't affect my fertilization rate. It didn't make embryos look better. It just made ICSI harder to do. So I've gone back to using PVP for all my ICSI and still do that today. Dish preparation is a fairly simple process, but can make or break the success of your ICSI program. I always say to make no more than 2 dishes at the same time. Every student must walk away knowing that the 3 things they can control in the IVF lab is the pH, osmolarity, and temperature. If you make more than 2 dishes, the osmolarity will shift and is the equivalent of probably putting a goldfish in a saltwater tank. It'll swim around for a while, but it will eventually die. And so will the oocytes during ICSI. I will show how I personally make a dish, but suffice it to say that there are multiple ways to make a dish. Just note that too small a drop, less than 10 microliters, needs to be covered in oil immediately, otherwise the osmolarity is going to shift. You will need pre-warmed PVP, oil, and a Heapy's buffered medium. I show in this slide the sperm wash media, to represent how I personally use sperm wash media for all micromanipulation procedures. A sperm wash is simply modified Heapy's buffered media, pre-supplemented with protein at 5 to 10 milligrams per mil. It's just easier for me to have one media for all washes and ICSI. And some people will do ICSI in a bicarbonate buffered media. I personally do not do this, but would caution if doing ICSI in bicarb media that pH now becomes a concern. And with this said, a lot of oil needs to be pre-equilibrated ahead of time and not to do more than 4 to 5 oocytes per dish, as the pH starts to shift after about 5 minutes and could possibly damage the resulting embryos. This slide is a visual representation of placing a 10 microliter drop of PVP in the middle and 4 wash drops around the outside in a plus sign. I personally believe this setup is optimal for saving time and going between drops and just going up and down, left and right. Single movements save time during ICSI, and we want to get those injected oocytes back into the bicarb media as quickly as possible. Proper scope setup will make learning ICSI much easier. Knowing how to focus up and down, knowing how the joysticks move up and down, and how the injectors will pull or push media. I like the term lefty-loosey and righty-tighty. This is something told to me when I was young, growing up on a small farm, and it still holds true today with the delicate microequipment. That being said, it's important to note that the tips of the tools have a slight angle downward, where the tip hits the bottom of the dish before the elbow does. If the tip is tilted upward and the elbow hits first, it will be impossible to immobilize sperm. The follow-up video will show the details of this process, and if using oil injectors, there cannot be any bubbles in the ICSI injector at all. The bubbles move slower than the oil and will make controlling the movement of the sperm nearly impossible to manage. Both air and oil injectors must have complete seals. If you pick up a sperm and it wants to keep going up the pipette, getting a capillary action, it usually means that the tip is not inserted into the tool holder properly. Once it's properly set and it's still pulling, it's probably one of the attachments where the tube is attached to either the tool holder or the injector and this pulling air from somewhere. Whether it's an oil injector or an air injector, it's getting its air from somewhere and could be a problem. I suggest setting up an algorithm for your development and always suggest working within limits. In the beginning, just load 4 or 5 oocytes at a time into your ICSI dish and only loading 1 sperm at a time during the injections. Once the QA shows that fertilization and development is acceptable, go ahead and do more oocytes and possibly load multiple sperm into your needle. During the injection process, inject slowly, and once about halfway into the oocyte, stop pushing and allow the zona to relax back over the needle. Place the sperm at the tip of the needle and aspirate a bit aggressively in the beginning with nearly a full turn of the oil injector or the air injector. Once the membrane breaks, immediately turn the opposite direction and begin to inject slowly. Push forward just slightly to get into the oocyte and release the sperm gently into the cytoplasm of the oocyte. The ICSI video at embryodirector.com is a great demonstration of this process. Once all the oocytes are injected into the dish, place back into the bicarb culture media and allow to incubate overnight. We do ICSI around the 1 o'clock hour of the day so that we can check fertilization around 18 to 20 hours post-insemination, which would be between 7 and 9 the following morning. I always say it's perfectly acceptable to do ICSI at 9 a.m. if you want to come in at 3 a.m. and do the FERT checks. It's my personal opinion that the oocytes that are mature at retrieval are the baby makers, and that anything that extrudes a polar body post-retrieval is likely not completed the full synaptic segregation of chromosomes during the first meiotic reduction of chromosomes. It is from these meiotic errors that we see some of our 1PNs and 3PNs from ICSI. 3PNs is most likely from not extruding the second polar body post-insemination, and 1PNs can mean many things. A 1PN with one polar body would indicate that the sperm decondensed, but the egg did not activate. And a 1PN with two polar bodies would indicate that the egg activated and thinks it's fertilized, but didn't extrude the second polar body, and the sperm did not decondense. In either case, these are not normally fertilized and should not be cultured for transfer. Here are a few other abnormalities with oocytes after ICSI. On the far left, you have a faint PN. You have to be careful that there's not a third PN in there before culturing on. The second one from the left is a degenerate or necrotic oocyte. And then the two on the far right, you have a 3PN, of course, is abnormal fertilization, as well as the 1PN with two polar bodies. The only thing that I would consider for culturing would be the one on the far left. That's a 2PN with faint PNs. If you weren't sure if there was a third PN in there. The only way I would consider it for transfer is if it did make a blastocyst. To summarize this lecture, I'd like to make some final points on maximizing your ICSI growth process. If you're getting 1PNs, note that there are one or two polar bodies. If there's one polar body, you probably need to aspirate more to activate the oocyte. If you're getting two polar bodies, then the egg is activating and your aspirations are good. You probably just need to be a little more aggressive with your sperm immobilization. I like to really kink the tail a couple of times before doing my injections, before loading and doing my injections. And make sure that you're doing consistently your ICSI every time, and then make small adjustments as you go forward. It is critical that the sperm comes in contact with the cytoplasm. In the early days of ICSI, we had large needles and injected too much PVP and had lower FERT rates because the sperm would not be in contact with the cytoplasm. Through this learning process, you don't have to learn that. So a good ICSI should yield approximately 70% fertilization, 50% blastocyst, and 30% good quality blast with freezable oocytes. I no longer use pregnancy as a key performance indicator because most of our cases today are either freeze-alls or PGT, and we do very few fresh transfers. So really, to do the quality management or quality assurance in the laboratory of the embryologist, you should really be looking at fertilization rates and embryo development rates. So as we stated in the beginning, your success is my success, and I would like to hear from your progress. If you'd like to schedule one-on-one training or attend a group training, email me at dranderson@embryodirector.com and see how we can navigate your journey. Thank you for watching.